Hi, thanks for tuning in to episode number 34 of the Doctor Podcast Show. We really appreciate your watching it. And I'm Dr. Robert Seichert, the host today. And if you like the Doctor Podcast program, we would appreciate it if you would subscribe and follow us. And if you like this episode or other episode of Doctor Podcasts, please click on the like and also the repost button. We also appreciate comments. If you have any ideas for a show, or if you have a specific person who you think would be excellent for the Doctor Podcast Show, please send us comments. We always appreciate those. Today I'm really pleased to have as my guest Dr. Remy Rabinovich. Dr. Rabinovich is a board-certified hand surgeon and hand specialist. He's a clinical assistant professor of orthopedics and also hand surgery here in New York at the Northwell Hofstra Medical School, which is a very prestigious medical school. He's also at the Lenox Hill Hospital Hand and Wrist Center, which is here in New York City. Thanks very much, Remy, for coming in today. We appreciate your taking the time to show up. This is a very important topic. Even though I'm an ophthalmologist, I see many patients who come in with various hand problems. They tell me about them, ask me for advice of what to do about it. I always refer them to a hand specialist like you. So tell us how you decided to go into orthopedics after 4 years of medical school. Why was orthopedics important for you?
Sure. Well, first of all, I'm excited to talk about hand surgery. I think it's not many people know much about it, but if it is something that affects many people, and we see whole variety of patients, and it's definitely exciting and fun to talk about. So what got my interest into orthopedic surgery? Well, I fractured my femur playing ice hockey when I was 16.
Wow.
And so that kind of opened the doors for me, and I knew pretty much since I was 16 years old that I wanted to do just that, getting people back into playing sports and living an active life. And so I pretty much went into med school knowing I wanted to do orthopedics, and I was fortunate enough to have an excellent exposure to hand and wrist surgery and elbow surgery during my residency at Lenox Hill Hospital, and I further pursued specialty training in that, and here I am.
So you did, how long is the orthopedics residency after medical school?
So it's 5 years.
5 years?
Yes, it's 5 years, and fellowship is an additional 1 year.
1 year, so a total of 6 years after
Correct.
4 years of medical. It went by like that, right?
In a snap.
Yeah, Lenox Hill is known for its excellent orthopedics department for many decades, so it's a very prestigious thing. How did you become interested in hand as a subspecialty? You mentioned you broke your femur. Why the hand?
So it's interesting. I love orthopedic surgery, and when a lot of people think about orthopedics, it's sort of this, doctor using power tools and mallets and hammers and drills and plates and screws and making bones straight and stuff like that. So what I love and what got me into hand surgery is it's a really cool and interesting mixture of that with sort of this very intricate, delicate, fine motor coordination work, and just the blend of that makes it very exciting, makes it very challenging, and I was hooked on it when I got my initial exposure to it.
Similar to ophthalmology, I also like it because it's extremely delicate and fine and precise, and everything has to be just perfect. Same with the hand. So the hand is one of the most amazing parts of the body. How many bones are there in a hand?
So agreed. I'm biased, but so 27 bones in the hand.
27
they're
bones.
all small, and sometimes difficult to fix. But yeah, it's 27 bones in this, small part of our human body.
That's incredible. And there are ligaments and tendons in the hand as well. Can you tell us what ligaments are and what tendons are? People sometimes confuse those.
The two. Absolutely. So ligaments are basically soft tissue connections between two bones, and they're oftentimes critical in providing stability to various joints, and tendons are attachments between a muscle and a bone, and so they're more responsible for having this sort of dynamic stabilizing effect, but also to help with movement and positioning.
I see. Now, there isn't that much room in your hand and fingers for all those muscles. So a lot of the muscles are actually in the forearm, aren't they?
Correct.
And then they connect to the different bones in your hand via the tendons,
Correct.
right? I see. So it's...
And then, so you have that, and there are small muscles in the hand. They're called the intrinsic muscles of the hand, and again, they're more so responsible for these finely coordinated movements that we often think of our hands are so important in doing.
Right, and one of the things that separates us from all other creatures and species out there is the thumb and finger apposition, right? Why is that important?
Correct. So again, it separates us from pretty much every other species on the planet, and it's important because without the thumb, we can't pinch, we can't grasp as effectively, and it's helped us evolutionize to who we are today. And
right.
People sometimes underestimate an injury to a finger, especially a thumb, until it actually happens, and then not just the thumb or finger is impaired, but the entire hand and sometimes the upper extremity. And so you'd be surprised with how many things you actually need that.
Yeah, we take it for granted, just like other parts of the body. You wouldn't be able to do hand surgery. I wouldn't be able to do eye surgery without that opposable thumb. That's really amazing. Tell us some of the common conditions that you treat. I see a lot of patients coming in with a variety of different hand pains. What causes hand pains? Are there specific things, or is there a whole large number of things that can cause that?
Yeah, so whole wide variety of things related to trauma, so fractures, anywhere, my practice specifically from the elbow all the way down to the fingertip, fractures, tendon injuries, ligament injuries, nerve injuries, different compressive tendinopathies, neuropathies, so basically things like carpal tunnel syndrome, trigger fingers, de Quervain's, tenosynovitis, all these sort of common terms that many people often hear but don't know exactly what it is.
Right.
But that makes up the bulk of my practice.
Tell us about carpal tunnel. In the last 5 or 10 years, as the computer era has taken over our lives, I see more and more patients who tell me they have carpal tunnel and are wearing all sorts of wrist guards and things. What is carpal tunnel syndrome? What causes it, and how do you treat that?
So carpal tunnel syndrome is, to put it simply, a pinched nerve in the wrist. So the median nerve crosses the wrist.
So it's a nerve on the inner part, right?
Yeah, so
right
the central
here?
part of the wrist, and it kind of crosses the wrist to go into the hand before it divides and innervates various muscles and sort of the sensation to the radial half of the hand. But this nerve travels in this sort of tight canal that's made up of a floor of bones and an overlying ligament. And for oftentimes for reasons we don't know, overuse or various different inflammatory conditions, this tunnel can get very tight, and there's a lot of pressure that builds up in this tunnel, and the nerve gets compressed. And when nerves get compressed, you feel it in symptoms like numbness, tingling, electrical pain, burning pain.
So you'd have those in your hand, all those
Correct.
symptoms.
Correct.
Okay.
And it's very irritative, and it often wakes people up at night. They can't sleep, they have to shake off their hand. And in very severe cases, patients actually lose muscle tone and function, and that can be a major disability. And as you mentioned, a lot of people now are constantly on their phones, constantly on the computer, typing, iPad, whatever it is, and that causes this sort of overuse and buildup of pressure within the carpal tunnel, and it can lead to these symptoms, it can lead to this condition.
Right. So let's say you have a job which requires you to sit at a computer all day and type, which is most of us these days. How can you prevent carpal tunnel syndrome? Is there a way to prevent it if that's part of your job and what you have to do all day?
Right. So it's tough to say whether there is sort of an exact protocol to preventing carpal tunnel syndrome, but there are ways that you can minimize some of the stress that the hand sees. Proper ergonomic setup, being conscientious of this, taking breaks, and if you do feel early symptoms, wearing a splint at night can help put the wrist in a state where the nerve is not under so much tension. And all these things can help, but sometimes just a person's biology can lead them down this track to having worsening carpal tunnel syndrome, and there's not much someone can do about it.
Right. So it's a combination of maybe genetics, you're prone to it, and also your environment
Exactly.
and the type of work that you do. You mentioned splints. I've seen those advertised on Amazon. Is it okay to just buy one of those on Amazon, or should you go to a hand specialist like you and actually get a prescription for the right type of splint?
Yeah, I think for the most part it's okay. They all serve the same purpose, keeping the wrist in a neutral position so that the nerve doesn't get tensioned with too much exaggerated bend in one way or the other. But there are professionals such as hand therapists that actually custom make these splints.
I see.
And so obviously a more fitted splint can help a patient tolerate it better and can enhance compliance and ultimately patients doing better.
Right. What about, I've seen ads for special computer keyboards that have a different layout, or mice for the computer that supposedly are better for that. Is that true, or is it just...
It's true. It's part of the ergonomic setup in basically getting your wrist in a comfortable position so as to not overuse it, and again, over time, increasing stress on your wrist to build up pressure in that carpal tunnel.
So you kind of have to experiment and find what works well for you and keeps your wrist comfortable.
Yep.
And reduces the pain and the other symptoms.
Exactly.
You mentioned also trigger finger. I see a lot of people complaining about that. What's trigger finger and what causes it?
So trigger finger is pretty much so similar to carpal tunnel syndrome, where there's increased pressure within a confined space, except it's not a nerve that's being irritated, it's a tendon. And so tendons in our fingers, they live in compartments, right? Our body likes to be organized.
Right.
And the tendons, specifically the flexor tendons that allow you to bend your fingers in to make a fist, they live in different sort of tunnels or compartments, and sometimes, for reasons we don't know, these tunnels get inflamed, and the tendons underneath get irritated to the point where they get stuck, they lock, and they catch on themselves, and it's very painful. And we often see it in patients who have some sort of inflammatory condition, whether it's rheumatoid arthritis, even diabetes, sometimes even a thyroid condition can set off this sort of imbalance in whatever it is, electrolytes, metabolites, that sort of changes how much fluid and pressure is within that canal, and it can lead to these symptoms.
So the tendon basically gets stuck in this tunnel and
Correct.
can't move, and your finger gets stuck. In that position.
Yep. And it creates this sort of vicious cycle where it gets stuck, causes more friction, causes more irritation, and this is something that can just get worse and worse and becomes intolerable.
What about Dupuytren's Contracture? I'm seeing ads on TV for that in the last 6 months or a year or so. I never really heard much about it. All of a sudden, everybody has that. Tell us about that.
Yeah. So it's funny you say that. Dupuytren's Contracture is something that definitely has, I think, caught attention. You see ads of something called Xiaflex all over the television, which
Right.
is one of the treatments for it, which I can get into. But basically, it's this sort of increased activity of a certain cell type underneath the skin. And it causes this robust tissue to just build up in the palms of the hands, which can be stimulated to be overactivated with any sort of blunt or penetrating trauma to the hand. And it's genetic, and it can be so bad where it leads to fingers contracting in and getting stuck. And so patients have a difficult time getting their hand in their pocket. They can't shake
So your
hands.
finger's stuck and you can't really
You
open
literally
it.
can't straighten it up. Even if you try and force it, you can't.
Right.
Because
so it's like a rubber band that's not elastic anymore.
Exactly.
Your tendon, it's just stuck and it won't stretch anymore.
Exactly. And it can be very debilitating. And it's nicknamed Viking disease because we think it's spread from that part of the world. That's why we see a lot of patients from that Northern European, United Kingdom area have this, in a vast majority of people.
We always like to blame other parts of the world.
It's the Vikings' fault.
Right, the Vikings did it.
They spread it to us. But, I've seen it in all, races and ethnicities. And, I think the treatment for it has come a long way, and we can manage it in a very minimally invasive way with injections nowadays.
Oh, that's good. And you mentioned the treatment, the medication?
Yeah, so Xiaflex, it's basically a solution that helps break down the collagen that's involved in Dupuytren's contracture. And so it doesn't get rid of it. Essentially you can't get rid of it. Your body just forms more of it. But it can help break down enough of this pathologic tissue where we as surgeons in the office inject it, and then in a few days have the patient come back, and we literally crack open their finger, break up this tissue, and patients literally regain their motion and their extension, and they're so super happy.
So it's a medication you can inject into the hand.
Correct.
What about injecting steroids into the hand?
So it's been talked about. It's been talked about, but this medication is more targeted exactly for this condition. It aims right to the exact pathologic tissue, or to hit the exact pathologic tissue that causes this and break it apart.
And it works well.
Works very well.
Oh,
Yeah.
that's good to know. What about hand, wrist, and arm fractures? Many years ago, I actually fell off my bicycle, and the handlebar hit me on the wrist, and the other side of the wrist hit the concrete. I had a hairline fracture here, which fortunately healed pretty quickly. I didn't even need a cast. I see a lot of people, especially in the winter during ski season, a lot of my patients come in and they have various casts on their hands.
It's the season right now. I see this all the time.
All the time. So how do people prevent these fractures other than just kind of sitting home and not doing anything?
Right. So, hand fractures from the elbow all the way down to the fingertip is super common. I see this pretty much on a daily basis, and it's my favorite thing to tackle and treat. They're challenging, they make you think, and there's so many different ways to skin a cat or treat these injuries that you can get really creative with them to really help patients restore function. But just like in your case, many fractures can be hairline fractures, or they're not displaced enough or shifted out of position enough where you need to go in and puzzle them back in. You can treat them with a cast or some sort of immobilization, and given everything heals well and patients rehab properly, you can expect a great function thereafter. But ways to prevent them or to help minimize them, again, just being conscious of what the risks involve, right? So if you're going skiing or snowboarding, wearing wrist guards, perhaps not going super fast, maybe taking it easy on the diamond runs, but all these different things, kind of being more aware of it and trying to be safe.
Right. For a hand or wrist or even arm fracture, when is a cast sufficient, and when do you have to do surgery? What are the indications for doing surgery for a fracture?
So, great question. This is a very, complicated topic in the sense that it depends on numerous variables, right? We take first and foremost into account an individual, right? Patient's level of function, right? So you would treat for example, one end of the spectrum, a high-level athlete, much differently than perhaps a 95-year-old woman in a nursing home for the same type of fracture. Right. So the patient's level of function, patient's activity level, their independence is super important. Secondly, we as orthopedic surgeons have specific radiographic parameters that we look at to see how much a bone is shifted out of place, and the fracture pattern itself is to deem whether a fracture is stable or unstable. And those fractures radiographically that are deemed unstable in combination with the patient's lifestyle help make our decision to tackle them with surgery or treat them more conservatively in a cast or a splint.
So is that just an X-ray, or MRIs are helpful as well, or both?
So usually it's just an X-ray, but in certain situations a CAT scan or an MRI is essential.
So you can see things better.
Correct.
And figure out what to do. How successful are the surgeries for a hand or wrist or arm fracture?
So I think overall they're very successful. And in many cases, not only are they very successful in terms of allowing patients to regain their function, but they actually accelerate the rehabilitation. So patients treated sometimes with surgery recover faster than patients treated in a cast, where you have to be immobilized for weeks on end. But not every case. There are a lot of fractures that are very complicated. There are a lot of fractures, especially with those certain fractures that have eponyms, and we all know in medicine you have an eponym. It's usually
Right.
not a good thing.
Right.
That just don't have the same level of expected outcomes as other fractures, and those unfortunately are much more challenging to treat and recover from. But I'd say for the most part, patients do pretty well.
Good. Now, you also treat elbows. You go up to the
Yes.
elbow, basically.
Yes.
How common are elbow injuries, and what do you do for those? Is that cast also or surgery, or again, it depends?
So it depends. The elbow is, in terms of fractures, I think overall we see those are a bit less common than the finger fractures and wrist fractures that most patients go to the ER for. But the elbow can be associated with a lot of very common tendon injuries, ligament injuries, tennis elbow, one example of sort of a tendinous sort of wear and tear degenerative
So
type of problem.
tennis elbow is a tendon inflammation around the elbow?
It's sort of like a wear and tear of a tendinous connection to one of the bones in the elbow. But the elbow distinguishes itself from the wrist in that it's a very unforgiving joint. It likes to get stiff. There's a lot of nerves and vessels that are around this sort of small structure, and it makes it very challenging to treat. Elbows often get very stiff, and so there's a fine line of treating elbow injuries, especially fractures and ligament injuries, with immobilization and getting them moving so they can recover their motion.
It's a pretty complicated joint.
Yes, yes.
All right. What about prevention of sports injuries? There are a lot of people who participate in sports. Is there anything you can do to reduce the risk of these injuries?
Absolutely. I mean, it depends on what kind of sport, but first and foremost, preventing overuse, right?
Overuse.
Making sure that proper stretching, mixing up sports, especially in a teenager or growing athlete, not sticking to the same sport all year round, right? Really having a combination of playing multiple sports, working different muscles, and that can help prevent injuries. And just being, again, conscious and aware of ways that you can sort of protect yourself. For example, in ice hockey, right, there are certain ways to anticipate you getting hit or checked into the boards where you can protect yourself and sort of absorb more of the hit, and learning ways to do that as efficiently as possible.
Right. What about ring injuries? People who wear rings on their fingers. I've seen a few patients over the years who had pretty severe injuries because something got stuck on their ring.
Yep.
Do you see that?
So those are pretty infrequent, but they are notorious and can be devastating, right? It's called the ring avulsion injuries, where the ring literally rips off your finger. And we've all seen gruesome images of that, but those are difficult to tackle because the way the tendon ruptures in that setting is very difficult to repair, and patients often don't do well with that.
Now, if that would happen, let's say some finger is cut off accidentally by a saw or something like that, can you reconnect that finger if you catch it quick enough and get the patient into surgery quick enough?
Absolutely. Those are something called replants, basically replanting the digit back to the hand. Overall, these patients don't do as well as some of the other problems that we tackle, but you reconnect the vessel, you reconnect the bone, you reconnect the nerve and tendon, and you can have a viable functional finger. A lot of it depends on the nature of the injury. So for example, a clean cut with a very sharp, fresh blade is much easier to repair because it's a very sharp type of injury.
Right.
And patients do better than, let's say, a chainsaw where things get ripped apart. And so that becomes much more challenging to repair, and patients don't do as well, unfortunately.
What should the person do if their finger does get cut off? What do you do with the finger that's severed?
Right, so you put it in ice, okay, that prolongs.
In a plastic bag and ice?
Plastic bag, ice, that prolongs the ischemia time. It makes the digit more viable before.
So less cells in the finger die.
Die off, yeah, and get to the hospital, preferably a big trauma center where they have a replant team and that can reattach the finger. And there are several of these designated hand centers in our area.
Right. So you mentioned you do carpal tunnel surgery also?
Yes.
What percentage of patients with carpal tunnel need surgery approximately?
It's tough to give it an exact percentage. And a lot of it depends on the patient, right? Sometimes patients, even though they don't need surgery, they don't feel like dealing with wearing a splint. They don't feel like dealing with having a steroid injection to help manage the symptoms,
Right.
knowing that these are often temporary modalities that put a Band-Aid on the problem, even though that Band-Aid can last for a long time. They just don't want to deal with that and rather have the problem fixed and be done with it with a relatively minor procedure.
So it depends on the patient's needs and
Patient's needs
requirements.
and how bad the condition is, right? If I see a patient that comes to me with pretty severe findings where I know that if you don't operate and don't address the carpal tunnel and let's say treat it with a splint, they're just going to do worse and probably have more dysfunction down the road. I'd recommend surgery to help minimize the progression of this problem and get them the best result possible.
Right. You mentioned the muscles get damaged
Exactly.
eventually. You don't want it to
You
go
wanna
to that
prevent that.
stage because then you'll have a weak hand
Correct.
afterwards. The surgeries that you do for carpal tunnel and the other conditions, is that done under magnification, loops, or microscopes, or can you do it just by looking at it with your eyes?
Yeah, I think so. The simple answer to that question is yes. You can definitely do the surgery with the naked eye. However, me, along with probably most hand surgeons, likes to wear loops, and so that magnifies our field. We are working with small structures,
Right.
and anytime you have a magnified view of the nerve, you can better assess it. You see everything in a much more pristine and detailed way, so that it helps. In terms of carpal tunnel syndrome, there's been many different advances with that. I think most patients have seen a scar from carpal tunnel release. It's a small scar in sort of the palm of the hand, but there have been newer trends to do this surgery with an endoscope, which is a small camera that goes into the wrist. And this is a more minimally invasive way that's less traumatic to the soft tissues around the nerve, and patients often have a faster recovery. Even though the results at the end of the day are the same, patients do well, these newer modalities tend to have patients or allow patients to have a faster recovery, which, for patients who are busy at work or athletes or whatnot, can go a long way.
Some of the specialists I spoke to in other specialties are now using robotics for their surgeries. Is that being done in hand surgery, or do you see that? Not so much.
Not so much. In orthopedics in general, we've seen a lot of development in spine surgery, hip replacements, knee replacements, but not so much the hand yet.
Right. So it's the larger joints where the robots are helpful.
Yeah.
Same with eye surgery. We still don't have robots that can do very fine eye surgery because it's a tiny little space. But I think in 5 or 10 years,
we'll see what happens.
We may get there. What about, tell us about the Hand and Wrist Center at Lenox Hill Hospital, which is, again, one of the finest orthopedics hospitals. How was your participation there?
So my practice is within the New York Hand and Wrist Center. We're affiliated with Lenox Hill Hospital, and the Hand Center is basically dedicated to the treatment of elbow, forearm, wrist, and hand injuries. We have surgical suites on the second floor of the building where we perform all of our surgeries. And on the 5th floor of that building is our outpatient rooms where we see patients. We have a procedure room where we do minor surgeries under local anesthesia, that patients that don't need sedation. We have an in-house x-ray. We have an in-house hand therapist who helps educate patients, make splints. And so it's a very comprehensive center where we deal with elbow to fingertip problems and have most things in-house. And so it's very easy for patients, and it's very efficient.
Right, and it also has a rehab center, so after
Correct.
surgery, patients are taught how to get their function back.
Correct, which is 50% of the work, right? So you can do the most perfect surgery, amazing x-rays, hang them up on the fridge, right? But not enough rehab or not compliant rehab, and patients don't do well. So it takes two to tango.
Right. What's your average week like, seeing patients in the office, doing surgery, things like that?
So I'm in the operating room 1 to 2 times a week. and I see patients the remainder of the week. And that's pretty much my weekly schedule. Sometimes weeks get busy where, for example, snowboard season or ski season, where you're just seeing nonstop a conveyor belt of wrist fractures and elbow fractures and various ligament injuries, where you need to get patients to the operating room in a pretty efficient and more expedited way, where you may be seeing patients 2 times that week and operating the rest.
Right. Is there a residency or a fellowship program there as well?
Yes. So I train orthopedic surgery residents at Lenox Hill Hospital. So typically I have a PA that helps me in the operating room, and I have an orthopedic resident that partakes in my surgeries.
So you're teaching them how to do surgeries.
Correct.
Great.
Correct. It's very fun. It's very rewarding.
Right.
And it feels good to sort of give back. You kind of understand mentors and people that you look up to took the time out of their day and trained you and made sure that you come out the best that you can be. And so it feels good to give that back.
Right.
And I have fun doing it.
Pass the knowledge along.
Yep.
And
Pass the torch.
Who knows, one day one of your residents may be working on your hand. Hopefully,
Exactly.
Hopefully not,
Yeah.
but you never know. I think you've seen the Tesla Optimus robot.
Yes.
They recent videos online on X platform
Yes.
and also in YouTube. And I was amazed a couple of weeks ago, they showed this robot folding a shirt with its fingers and picking up an egg without squashing it and just kind of flexing its fingers. It almost looked human-like. What
Right.
do you think of that robot and its abilities with its hands?
So super impressive.
Yeah.
I saw that video of the robot folding the laundry, the shirt.
I could use that at
Yeah,
home,
I would
right?
love to
Yeah.
have that. So I know that Elon Musk mentioned how that their goal by the end of, I think, 2024 is to have it, thread a needle. So we'll see where that goes. But super interesting. The dexterity that's involved in that robot is nothing like I've ever seen. And we'll see if that'll be applied to, our surgeries in the future.
Right, it'll be...
Hopefully we still have a career.
Right. Who knows? The robot might put us out of work. The thing is that in addition to our mobility of our hand, we have sensation. So for example, if we pick up an egg, we know to be gentle with it, as opposed to picking up a brick, which you have to grasp harder. If you try to pick up an egg like you pick up a brick, the egg will crack. How does the robot, or do you know, how will the robot sense what it's touching and feeling, and how tight a grip to have on that object?
Right. I mean, that's a great question. Simple answer to that, I don't know. But, what separates us as humans is we have these, different proprioceptors and sensory nerve endings that can help distinguish, the fine touch, deep palpation, what's rough, what's soft, and maybe recreating some of these proprioceptor-like or sensory nerve ending-like functions in this robot can help push it to the next level. So we'll see.
Right. I'll be afraid to shake that robot's hand initially because...
Could break your hand.
Right. You don't...
It's okay. There are hand surgeons that can help.
Oh, all right. Glad I have you here. What about research? Or do you participate in research as well?
Yeah. So being part of Lenox Hill Hospital, we do have a research department, and most of the research that I partake in are more clinically oriented studies looking at outcomes of various different surgical techniques that we use, and seeing how patients do after certain procedures, mainly case series, case control studies, stuff like that.
So it's clinical research.
Clinical research.
Figure out what works best and what you should do in the future. And what about any recent success stories from your patients? Can you give us an example of?
A recent success story. So the first one that comes to mind is a surgery that I did fairly recently. It was an elderly woman, 75-year-old woman who fractured her distal radius, which is part of the wrist, 3 months prior to seeing me.
So that's the bone...
The forearm bone kind of like closer to the thumb.
Oh, all right, on
Right
this
there,
side.
exactly.
See, I forgot. I
Yeah.
knew that in medical
So
school.
she fractured that, and for 3 months, it basically ended up healing in the wrong direction. So if you can imagine, the forearm is kind of aligned with the rest of the wrist and hand.
Right.
Her wrist was pretty much like 30 degrees angled in the wrong direction, and that poses a significant challenge in washing your face and combing your hair and using a toothbrush and feeding yourself and
Right, everything.
And she was independent. She was relatively active, and she, had like significant functional limitations because of this. And so I went in and I rebroke the bone and realigned the distal radius so it lined up with the rest of the forearm, and put plates and screws to stabilize that, put in bone graft, which is basically like a bone substitute to help augment healing. And this helped her regain normal alignment of the wrist. And with time, she rehabbed it, regained more motion, and was one of my happiest patients.
Wow, that's an incredible success story. You mentioned you had to re-break some of the bones to get it aligned properly. Do you do that under general anesthesia, or is it local regional anesthesia? What kind of anesthesia do you use?
Right. So typically, I use regional blocks for my surgeries, where the anesthesiologist, they use numbing medication, to put it simply, and they inject around the brachial plexus to pretty much numb up the entire arm.
So they inject up here around the shoulder
Correct.
area, and that numbs all the nerves going down into
down.
the arm and the hand.
Yeah, so patients don't feel anything, and they can be totally wide awake and not feel anything and go on with the surgery, but most
That's
patients
great.
are sedated, they're comfortable.
Right.
They're having a couple, cocktails in Miami while I'm doing my surgery. And
Sounds good.
Yeah, and so I did this case under that kind of anesthesia, and this helps with pain control after surgery because that block lasts for several hours. So patients are comfortable when they get home, they can sleep at night, and that's typically how I do my surgery.
I guess in young kids you have to use general anesthesia, where you
More
put
so.
them to
More
sleep
so,
because they
correct.
won't stay still for that surgery. Well, this has been an incredibly fascinating discussion. I learned a lot. I feel like I could be doing hand surgery after talking to you.
That's awesome.
I really want to thank you very much for taking the time to come today and speak with us about this very important topic. Thanks very much.
Thank you very much. It was a pleasure. I had a lot of fun, and now people know a little bit more about hand surgery.
Yeah, that's great. Thanks.
Thank you.